the day talking about the Institute of Medicine report, and I think that we want to keep our focus on this area of health information technology, analytics. David, since you were one of the co-authors, and Jim also, and David Klassen, frame for us what are the critical issues that are important today. Specifically, what's most important about this topic that you feel we need to understand nationally and globally? When we think of a 30-minute panel, we can only learn so much. What do we really need to know that's actionable that we could really take to heart?
It's essential that providers be able to report issues when they identify them. That's true about safety issues in general. It's also true about safety issues in particular. And one of the things that we found in doing the report is that there are some instances in which providers have been actively discouraged from reporting, especially around HIT-related issues. And that clearly is a problem. It's not a good thing. People need to be able to share their stories, and that's a way of preventing having these things happen again and again, which is what happens when you don't report them.
Jim.
Well, I think just building on what David said, we see some of the things have to do, I would say, less with where the ones and zeros go, but how they're implemented, both going into the baseline training to realize, and it was mentioned a little earlier, I think, that the HIT, health information technology, is a tool. And if we're trying to automate or systematize how we do business, we have to have good processes. We just don't automate lousy processes. Sometimes it might be that the software might not be as well suited to the processes we need. And in other cases, our processes should be varied or changed to take advantage of the power that the HIT gives us. And often that doesn't happen. I think the one thing we talked about a lot was the issue about usability testing, human factors parts of the interface, because there are many cases where the information is there somewhere, but it's not readily accessible, or it can be manipulated in confusing ways, or people can execute things that they didn't intend to do. And how do we learn about that? If there's reporting. Otherwise, sometimes we don't even know the mistakes that occur or the harm that's caused because they go unnoticed. And that has to be done in a more proactive way than done now.
So let me tell you a little story about this meeting. So when we had HIT in the title, we lost attendance because it said Patient Safety Summit and HIT, and no matter how you spin it around, there are people in patient safety that go, oh, that's for CIO. And we always see the numbers go down when we cover something technically, if we cover, because we're so supportive of what you all are doing in terms of using information in IT, and we believe it's really important, even though that is the case, and even though we see numbers drop off, we want to support it because we know it's so valuable. When I talk to the people in the board, I say, listen, when you look at your IT guy, right now, he or she is 10% I and 90% T, and in 3 or 4 years, that person's going to be 90% I and 10% T, and you better start paying attention to the I because that's how you're going to get paid. That's how you're going to keep your patients safe. But I have to tell you, the numbers go down. Oh, this is the IT session, and people might go out for a cup of coffee, even though it's patient safety. And when I talk to the people in the boardroom, and I say, you've got to put money in this. Oh, we already bought the EHR. No. I said, this is patient safety. We're using the information. No, that's, too much to deal with. David, you're out interfacing with people. How can we communicate to the non-wire head, forgive the expression, in the boardroom that we need to put money, knowing that we're going to have cuts after the election? I mean, I don't have a crystal ball, but I also can do the math, and we're going to have cuts. I mean, we're $100 trillion liability. We know they're going to cut things, and it's going to be around training and safety and consulting and all these other areas. How can we get the message in the boardroom to do what Don Berwick said, start a escape fire? When you don't think you should pull out a match, you need to light the fuel in front of you that's going to save your life. But we see it drop off.
I think the answer may be that we're building a learning system. And we will learn after having spent all the money on EHRs and HIT that just putting them in and turning them on doesn't lead to their improvement in quality and safety and all those other things, and that the implementation doesn't stop when it's turned on. That's just the beginning, and that we'll go through multiple phases, I think, of iteration to learn how to use these systems more effectively. And I think maybe that's the message that we were trying to basically put in our report when we talked about the life cycle of IT. We had a whole chapter on that, which said that you need to think of this as a continuous process of improvement, not an IT implementation. But I think a lot of organizations, when they start down this road, they tend to think of this as just an EHR implementation. Put it in, turn it on, and then that's it. And then when they realize that that doesn't give them all the benefits that they were promised when they bought the system, I think we get to Farzad's point. It's not about whether we're going to have HIT. We're going to. It's how we're going to use it to improve performance, I think. But I think that's a natural learning thing that occurs for all organizations. And if you look at the pioneers in this area who've been doing this with homegrown systems, David, I think it's fair to say you guys have learned that at the Brigham for years, right? Which is your improvement cycles, as you and I talked about in an editorial about meaningful use, right? These improvement cycles are critical to learning how to use these systems to improve.
Yeah, I couldn't agree more. A lot of people, when we talk about information technology, they'll say it's the solution to all of our problems. And a lot of times I tell people it's also the problem to a lot of your solutions. If you just think you're going to buy this thing and it's going to make your patient safer because you paid a lot of money and you bought the system and you flipped some switches, you're wrong. The safety comes from building the systems that are going to deliver safer care, and the information technology can be very helpful. And I think in helping us understand, getting data out faster, helping us understand how we improve the system, how are we doing, you mentioned, where are our vulnerabilities, how are we doing in addressing those. But the information technology systems are not going to solve these problems. They're going to help us, give us the information that we need to solve the problems. They'll give us the information faster so we can get to these solutions faster. But simply thinking that you're going to buy a system and it's going to solve all your problems is a big mistake.
Bill. Well, there are a couple of things about electronic health records and other information technology. And people, when something goes wrong, when somebody puts the orders in the wrong record or what have you, people think about it and they worry about the IT. What people don't realize is there were a lot of errors with paper records. A huge percentage of paper records aren't there when the patient shows up in the office or in the hospital. And so there are errors that happen. They just aren't as visible. So, again, back to the point that David reiterated, it's not whether we're going to go to information technology. We are. It's just how can we do it in as safe a way as possible. And what I would submit is that information technology brings tremendous new power in terms of the ability to analyze and understand what's happening with patient safety across the board, not just IT-related patient safety. And one of the things is that a lot of patient safety errors can present in a number of different ways. They can come from IT. An infusion pump can malfunction, give the patient too much, and they can fall. And it presents itself as a fall, but it really relates back to IT. So you really need to report on all kinds of patient safety events in one way, not separating them out into the silos as they have been oftentimes. And the other thing about it is that you mentioned before the cost of collecting information, data collection for reporting to all the different people that want to do it. It's very expensive to do that, and it's been very fragmented. Different agencies ask for different information. A lot of it also, because of the burden of data collection, we go to what's on the bill. We do a lot of reporting around administrative data, and the great, huge reservoir of information on clinical performance is buried in paper records or even buried in IT records where the code's written differently for different vendor systems. But if we get together through meaningful use and other ways and we harmonize things and harmonize the measures, we can begin to use the power of IT to vastly decrease the cost of reporting and increase the power of analytics. So IT is going to be a godsend to quality and safety in terms of lowering the cost of obtaining the information and increasing the power of analytics. And I would also say that, and there was a point made earlier by Arjun, and you should know that those of us that are feds and others that are working with us understand that care changes at the local level. At my agency,
we don't treat patients. We're not going to make care safer tomorrow directly. We do it by what we help to disseminate. But care has to be changed at the local level. So what we need to work for, and the Partnership for Patients, interestingly, has highlighted all of fragmentation, not just at the local level and measurement, but it's highlighted the fragmentation among the agencies. And ideally, what you want to have is that hospital that's out there that has all these reporting requirements. They got the state, they got the Joint Commission, they got the FDA, they got the CDC, et cetera, et cetera. They got their PSO now. They're drowning under data requirements. We need to harmonize what makes scientifically supportable clinical sense to report. Focus, as was mentioned earlier. Let that hospital report once into its event reporting system, then have that information go off to everywhere it has to go to. That will decrease costs, which will help at least a little bit, maybe not too much, but a little bit with your problem, with what happens after the election and costs get scrunched.
So we've got trustees. How many trustees do we have in the audience? Okay, so for my trustees that are out listening, who are going to watch this later, who we're targeting, who we're training trustees and certifying them in leadership and patient safety to help equip them to see what to empower them. One of the things we always say is you don't need to know all the answers, right, Sharon, Rosemark from Chicago? You just need to know the right questions. So given that we're heading into an environment of not getting more money, but probably getting less money, not getting less stress, but probably getting more stress, what are the questions that really responsible trustees need to ask of their senior professional administrative teams, their CIOs, and because we can equip them, because they have the ability to open some purse strings that are not part of the budget. Because right now, my 3,100 hospitals, every one of them is cutting budgets. They're cutting capital, they're cutting everywhere they can cut. Yet, our trustees control money that's sitting on very little investment income that they could put to work to save lives. We got 30 preventable deaths an hour. They would spend money if they knew it was taking a good bet. So, David, what should a trustee that's not a clinical, not IT trustee, what are the questions that are proper questions about resources other than, hey, how much do you want?
Well, I have a couple of specific suggestions. One, I think it's useful to ask, what are your rates of major safety events? How many hospital-acquired infections are we having? How many adverse drug events? How many falls? How many pressure ulcers? Those are the main things that hurt patients, and they all result in losses to your institution. A second set of questions relates to how are we performing in terms of quality on an ongoing basis. It turns out that organizations that ask that kind of question on a regular basis, in which the board is involved, do better in terms of quality. And a third question I would ask is, how is your organization using analytics, and what are you doing to learn from analytics? Throughout industry, analytics have played a really big role in improving efficiency. I'm a big fan of a book called Competing on Analytics, which talked about how a variety of industries have done that successfully.
David, your thoughts. What does the board or the professional administrative team have? What should they be asking?
Yeah, I think in other industries, it's sort of an accepted view that technology is adopted as aggressively as possible to increase the performance of the business, right? And that means aggressively asking, we made this huge investment, are we really maximizing it to see improvement in quality and safety? And Bill and I are very involved in how we enhance reporting of safety problems through the PSOs. And clearly all that we've done in common formats was done with the idea that we create standards that would be built into electronic systems so people wouldn't be doing this on paper. So we spent an awful lot of time doing that. Now we're very focused on how we might leverage existing data and EHRs through automation of triggers to enhance reporting into PSOs. Another very rich area of how we might improve measurement and reporting that's just sitting there waiting to be harvested, as we've talked about. So I think there is sort of philosophy in other industries, get the most out of your investment in IT. And unfortunately, I think we very often believe, as Arvind said, put it in, turn it on, and we're done. That's only the beginning.
Either magical thinking or it didn't work, and we all pull out that exception that was a train wreck where they had to tear out the CPOE system and say, the exception's always pulled out. I want to go to Jim.
But just let me finish one other thing. Traditionally in safety, we've been retrospective. We look at these events after they happen. Now with EHRs, I think as Farzad had said, we have the capability of identifying as they're happening and intervening in a way that sort of throws our old view of preventability right out the window, right? We always thought preventability is the only key. What if you could identify them as they happen and intervene, mitigate, and ameliorate? That, to me, is the next step in safety, and that's what I, as a board member, want to do. What are we doing to leverage all our HIT to uncover problems as they happen and deal with them?
So, Jim, you are a very persuasive speaker every time you and I get together and make a compelling argument for things. I'm going to give you a scenario. So, election happens, budget cuts, there's $200,000 at play, and you're in the analytics and the patient safety IT area, and you got to make your case to get the 200 or not lose your 200. What are you going to what are the 2 or 3 things that you could say to a board? Because this is what this is what's going to happen and happening right now. What's the compelling story to say you can't cut my budget, or I need to get that donation that just came in?
Well, that's still a question. I think the first thing it would depend on is you should have laid the groundwork already of what is the utility of the HIT services I provide. To just come and say I need $200,000 isn't persuasive. So, well, I think if you're waiting to tell the story once they're going to cut your budget, it's too late. You've already lost the game.
You've already lost it.
I would say you need to be saying, why is this a priority? How, by using, the analytics we have, how has it helped us deliver better care, deliver more efficiency, less waste? If you haven't done that already, then you already haven't done your job, and you should be cut, I would say. And I think that's where it comes to how do you prioritize, how do you justify every day? I mean, you should always think in your mind, I believe, why is what I'm doing today worth doing? Why shouldn't I be zeroed out? You almost should start every day with a zero budget approach. Why do I add value today? I might have added value yesterday. Why am I doing today? And if you're not always reinforcing that with your board, with your leadership, and if you're not thinking that way and how you guide your actual activities, it's too late when somebody finally asks the question to start thinking about it then, because you don't even have a track record that would support it.
Regina Holliday and the team that were up here, the consumer group that were up here, talked about the fragmentation, and I see that in our test bed. I see the fragmented silos. Silos kill, they really do, and they're going to kill budgets if we don't kind of rally together. Arjun, you have a really great view nationally. For those people that don't think we can get way down to almost zero on infections, you're seeing some pretty great numbers that you're seeing things really, people are surfing the tsunami, right? You're seeing people get the board out, and they're now really moving. What's your message to the rest?
Is get on board. I think that we know a lot about what works. We know that it comes up over and over again, if you focus on problems that we know have solutions. Healthcare-associated infections are a great example. Central line-associated bloodstream infections are an ideal example there, where relatively simple measures that are applicable anywhere in any healthcare setting where you're inserting and using central lines, it's taking those measures and applying them. And I think what we're seeing now is the uptake. We are seeing more and more people look at that data and say, it's unacceptable to do it any other way. And I think that's the model that we need to be striving towards, is where unsafe care is simply viewed as being unacceptable care. And patients won't accept it, boards won't accept it, clinicians won't accept it. When we reach that, that's when we've won this battle. And I think we're getting there. Certainly with healthcare-associated infections, central lines, things that we might have done as residents or even as young attendings, now it's unacceptable. And there's a culture that does not accept that. And I think that's what we're working towards.
And I think that's the next great barrier for us in safety is culture is, I think, one of our greatest barriers to improvement, to actually getting everyone on board, right? We know what to do. Now the question is, can we execute it?
We've got rural hospitals represented here that have very unique challenges. Mike Williams Hospital operating at about 50 beds. Fredericksburg, Texas, they only have a certain size. They can only do so much. Many of the other hospitals around the country have far less staff than you do, Mike, in infrastructure. Any tips, any advice, any good success stories for this, 2,200 hospitals that treat about 25% of the care, between 20 and 25% of the care in America are in small hospitals that are in real jeopardy. They're either the number 1 or number 2 employer in those communities, and people don't realize when they go under, the community's going to go under, and a lot of them are just barely making it right now. Any tips, small hospitals, don't have a big infrastructure. Any tips, advice, stories? Bill.
Yeah, definitely. And let's pick up on the central line example that Arjun used, because I think we've all talked about how the fact that science has revealed certain ways to do things that are safer, and yet the problem is dissemination. healthcare is a very, very complicated industry. It's very fragmented. There are millions of people working in it. So how do you get that innovation down to the local level? And working within our agency and now with a Partnership for Patients and with CDC, we have a package where we've taken actually some of the things that have been talked about today, checklists, teamwork, culture, packaged it up in something called a Comprehensive Unit-Based Safety Program and rolled it out through the American Hospital Association, all the state hospital associations and departments of health, and it's on the web, and it's actually ideal for small hospitals because it's a very easy to adopt package. There's technical assistance and help.
Fantastic.
And we're actually now in 27% of the ICUs in the United States with this very package. And we've seen a 40% reduction from an already reduced base just over the past 8 quarters. So I think this is an example. Now we're planning to move this into
I
other
know where you can publish
areas.
that.
Yes, that's right.
I think you should. How many people want to see that published? More work for you guys. Arjun, thanks for coming from Atlanta. We're at time. Great panel. Thank you very much.
Thank you.